Hello, we're delighted to welcome you to this recording of an educational session exploring Parkinson's from the perspective of all healthcare professionals. This online event was streamed to an audience of occupational therapists in autumn 2020. This talk is going to be based around a resource I've created, a map of Parkinson's, and we'll be looking at the section tonight about sleep and nighttime, because it seems from a lot of what you've said in the chat box, a lot of you have worked with Parkinson's for a year or many more, and you'll well be aware of the fact that night times is a whole issue in its own right for people with Parkinson's. And although it doesn't fit into any categories of, symptoms, for the purpose of my map of Parkinson's, I've decided to look at this as a subject in its own right. And to start with, we'll think about the kind of motor side of nighttime and Parkinson's, the nighttime akinesia. And I've got a couple of examples of that within the map of Parkinson's. We'll have a look at a video now. This gentleman with a very tremor-dominant form of the condition. He attended our clinic and was using this knees first, pitch forward technique for getting into bed. A great effort when the actual sheets and blankets or the duvet was in the way. He came in to demonstrate this for teaching purposes. And the whole maneuver to just from touching the edge of the bed to getting himself into a comfortable position actually takes him 29 seconds. So a fair deal of time and effort involved in that process. So we'll now look at the same gentleman after he's had a session of treatment, learning an alternative method to get into bed from a therapist. And here he goes. And this time, from touching the side of the bed to lying down, it's taken him 8 seconds. And when we bear in mind that people are often up multiple times a night, that time and effort is going to make all the difference. So he's now going to show us the technique for getting out of bed. And here we go. Now he's going to demonstrate the movement strategy that we typically teach patients to get out of bed. Bend knees, turn head, drop knees, reach over, and roll. Legs over edge, and push to sit up. So those words very specifically, or something very close to that, will be taught along with that movement sequence, because one of the things we know about these very basic movements is that they're learnt before we develop language. Pre-linguistic motor skills, they're called. So when we teach someone an alternative way to move, teaching them keywords, the verbs and nouns to drive the movement is also very useful, which is why I use that particular set of phrasing. So we'll now look at another example of a woman who's struggling with bed mobility, and I'd like to tell you a bit about this lady's background while we watch her struggle. So when this lady came to us, she'd spent 2 years sleeping on her sofa. Because of her difficulty getting out of bed, she discovered her own way of coping, which was basically to sleep on the sofa, roll off onto the floor once she wanted to get up, and then crawl on her hands and knees out into the hallway. And then she used spindles on the banister, like the vertical posts on the banister rails on the staircase, to pull herself to a standing position. So that's what was actually going on in her life when she came to meet us. As you can see from this, the fatigue, her weakness is getting more and more now. She's getting exhausted. She's struggling and struggling. But I would like to assure you that she actually really enjoyed her day's filming and offered to come back if ever we needed any more help. So once it gets to about 1 minute and 3/4, we ask her to stop, because she's clearly not going to be able to get off that bed as things stand. So we now see the same lady using a very simple device. So let's go on to that one. So here we go. She's now going to use the bed stick, same movement sequence as the gentleman just demonstrated, but just with that added power. I believe bed sticks, when you buy them by the 50, cost about £20 a go. So a very simple solution to that awful struggle. But akinesia at night is not the only problem people have. So we're going to cover these other topics as well. So looking first at nocturia, so the frequent need to get up to pass urine at night. You'll find it's not uncommon if you ask your Parkinson's patients about this, that they'll be telling you that they're getting up anything between 3 and 10 or 12 times a night to pass often minute quantities of urine. This very common problem in older people and particularly in Parkinson's. And as you can see from the images on the screen, there is quite a lot of general advice that people can be given in terms of their fluid intake and increasing fluids earlier in the day, drinking plenty of water up until early evening, and then from early evening onwards to restrict particularly alcohol and caffeine containing drinks in the evening, and only really drink when you're thirsty at night. By doing that swap in fluid intake, often with a lot of encouragement, because people tend to limit their fluid because they think that will reduce the frequency of urine, but actually it has the reverse effect, as you probably know, that limiting fluid intake actually irritates the bladder, the urine's more concentrated, so people have to get up very frequently even though they're not passing large quantities. So quite often people need quite a bit of persuasion to experiment with this change of their fluid balance, but invariably when they do so, they'll find that they cut down that frequency at night very significantly, maybe only getting disturbed once or twice compared to, you know, half a dozen or a dozen times. Obviously, you know, thinking about getting to the toilet safely with lighting, perhaps needing equipment in the bedroom. I found this amazing picture of some sort of brass commode urine bottle down the bottom, but we know that making sure that people have the right fluid balance and the right facilities is going to make their nights a lot easier on that level. So moving on to some other sleep type issues, I think this is much more difficult for people to kind of have their issues identified. Really, in busy clinics, quite often we miss out on problems around sleep and dreaming. And there's two sort of main issues around dreaming. Some patients with Parkinson's are just experiencing vivid dreams, and they can be quite pleasant. Other people are getting nightmares, and it's really causing them a lot of problem. And those things can actually be related to the medication regime, and particularly to the strength of the medication in the system on retiring at the end of the day. We'll come to this later in the questions, because there's a question around this that we can develop this further in our conversation. But certainly to say that these things are bothering people, and REM sleep behaviour disorder is another dream-related condition that troubles a lot of people with Parkinson's. And I wanted to focus on this a little bit more because there's quite a lot of dream and sleep disorders, and REM sleep disorder is not sleepwalking. So I've got a picture of a man on here on the roof sleepwalking. Luckily it's just a statue. But REM sleep disorder is a different condition, and it is common in Parkinson's disease patients, and particularly injurious to people, particularly the men who've had military experience. In what I found was they would have quite shocking dreams that during REM sleep disorder, the normal paralysis of the body during the dream is lost. So the body moves through the actions of the dream. And quite often you'll come across patients who actually injure themselves during their dreams. They hit their arms on the furniture beside the bed. And the picture down in the bottom of the screen with the lion and the lady was put there because it reminded me of a patient who came in with very bruised and injured to the clinic. And I inquired what had happened, and he told me that a couple of nights earlier, he'd had a dream where he was back in the desert where he'd been in the war, and that he was in the back of a Jeep, and all of a sudden a rhinoceros leapt into the back of the Jeep. So he threw himself out of the way and he hit the wardrobe. So he actually physically threw himself up off the bed in this part of the dream, and really injured himself. And if you have the chance at conferences, or you look around online, you can actually see film from sleep laboratories of people going through this, where they're lying down, their eyes are shut, but their bodies are moving. So they may be just gesticulating as if they're and talking. Sometimes I've seen pictures of people like having a little punch up, a little fisticuff, but still lying down. And then other people, they literally leap out of the bed when they're jumping off a wall in their dream, or leaping out of the way of a rhinoceros. So this is something that's really important that we understand that it's a different condition in its own right from the vivid dreams and the nightmares. So sleep, difficult. And then there's the getting to sleep. So insomnia, both problems falling asleep and staying asleep, and then the opposite problem, the daytime sleepiness, are all things that can affect people with Parkinson's. And again, the medication can feed into these in quite a few different ways. So for daytime sleepiness can often relate to the total amount of levodopa medication someone's getting on a sort of daily basis. And sometimes the daytime sleepiness is a result literally of them having a quantity of medication that's making them very sleepy. It can also relate to trouble with falling asleep at night with the actual insomnia. But a good Parkinson's medic will be able to refine medication doses to help probably with both of these problems, whether it's the trouble with falling asleep and staying asleep or the daytime sleepiness. They can both relate to the sort of dopamine levels in the system. And then get more problems with nighttime, poor people with Parkinson's. So we mentioned akinesia earlier on, but also there can be quite a lot of problems in the night with dystonia and very painful distortions, particularly around the foot dystonia at night, which can be quite a hazard again when people are trying to get up to use the toilet frequently. That another thing that can be helped by changing medication doses. Often if people are taking enough medication to get through the day and the night, except the dystonia, sometimes even a rescue dose in the night can be arranged with the medic, so that if dystonia happens in the night, a person can take a very quick acting short dose of liquid levodopa, and in that way they can relieve the dystonia. And the other thing that I wanted to mention was this restless legs and periodic limb movements. There's a picture of a cat in the corner of the screen here, because actually the periodic limb movements during sleep is a condition that sometimes you see in animals. Sometimes you see them just doing a kick from time to time. That can happen to anyone, but it's also quite common with people with Parkinson's. And then there's the restless legs, which is more a trouble with while they're awake. The periodic limb movements are during sleep, but the restless legs are unpleasant feelings that people have when they're trying to get to sleep. So all in all, night is far from peaceful for people who are going through one, two, or many of these different symptoms overnight. Thank you for your attention. We trust you found this session interesting and that you'll make time to view other recordings in this 6-part series.
To find out more about a Map of Parkinson's course for healthcare professionals and a Map of Parkinson's app for everyone, visit us online at Phoenix-Aragon education.uk.